Hi, my name is Peter. I'm an emergency physician resident in Stockholm, originally from Denmark. And today I want to talk with you about one of the essential presentations that we see in emergency medicine, abdominal pain. And I want to do it a little bit different than many other sources on this topic do. I'm going to do it from an emergency medicine perspective, and I don't see a lot of FOAM, free online access medical education, on this topic. So that's why I wanted to do this video as well, so that you have a video where we kind of take the probabilistic approach, and I'll give you some tips and tricks on how to approach these patients. And for the part 2 of this series, then I will do a more thorough walkthrough of the gynecological patient in the emergency department, and with a bit of obstetrics as well. But this first part will be on the acute abdomen in the ED. So I'm not going to go through any other surgical problems like proctological problems or GI bleeds. That's for another time. So this is solely about the acute abdomen, like pain in the abdominal region within 14 days of onset. Okay, so let's move on. These are the two parts that I'm going to go through in this series. And we'll start with the abdominal pain part. For those of you who do not know about this book, this is one of the like Bibles in I guess surgery or abdominal pain, at least. It's called, like, the author of this book, Copy, or Zachary Copy, or Sita, as he's called sometimes, also as a pseudonym. He wrote this book maybe 50, 60, 70 years ago, I think. There is, like, now the Copy's approach to abdominal pain book is maybe its 22nd edition. And I just wanted to, many people don't know that he also made a book about the exact same book, but just in rhyme, which is kind of peculiar, but it's really great. And I managed to find this for one of my friends whose main area, or not main area, but who loves the abdominal pain patient and has great experience with it in the ED. So if you ever come across this book, then I would advise you to buy it, and then just check out the rhymes, because they're both quite good, and also with good knowledge on the abdomen. Okay, and this is the start page of that book, The Abdomen as a Stage. All right. These are the references for approach to abdominal pain, just some of them. I did include some GI bleeds, just ignore those. But main source is Copy's abdominal pain. I think EM Crit also, that's the sole book that they advise to get for abdominal pain. And there seems to be a lack of references for emergency physicians on abdominal pain, because I'm not sure why. I'm not sure whether it's because the surgeons mainly own this space internationally, or emergency physicians don't find it difficult, or I'm not sure why. But I think it's not not necessarily an easy area, and that's why I'm going to go through it with all this, with all the small bits and pieces that might be in the approach to the abdominal pain patient. All right. Another great book for Scandinavians is this, like the Kunskapsstöt, the book in Stockholm, which was newly updated. And I guess for Scandinavians, this is a great one-stop resource for a lot of this stuff. It's not necessarily as evidence-based as it could have been, and as we'll go through, a lot of surgery isn't. or at least, and that's not a critique. It's just more like something that we have to discuss when we approach these patients and get into this world of surgery, and where it's more mechanical. All right. So moving on to the other references here, and a lot of this is from foam. And there isn't a lot of foam on the abdominal pain, as I said. So you can. This is what I've been able to gather, and you can check that out. All right. So moving on to the disposition. So what I'm going to do is just. I am no high expert in the approach to the abdominal pain patient. I'll try to mix in some non-technical skills and some other things that I find interesting and find relevant for the approach to the abdominal pain patient. But for the more like in-depth, thorough walkthrough, I would advise you to go through some of the references that I just went through. But here I'll just give you 5 areas, general areas that I'll go through, and some of them will be quick, and others will be more in depth. When you approach the abdominal pain patient. For the more specific on which blood samples goes up and which diagnoses and illness scripts and like how you diagnose gallbladder disease, that's not this lecture. That's another lecture, and there are several great ones out there on YouTube and on the references that I just posted. This is more like a general tips for the approach to this patient group. So the first one, epistemiology, and when we walk into the scene of the surgery part of the emergency department, then epistemology-wise, where do we know how do we know what we know? That's epistemology. And I've talked about there's different. I've earlier talked about there's maybe 2 or 3 different ways to approach this, where we know what we know. How do we know that this patient has this disease? Well, there's the mechanistic argument or physiological argument, where I know physiology good enough, and I know that the abdomen is like this. Then there is the experimental. Whether we have experience or not, and this could be either personal experience or literature experience, meaning evidence-based medicine. So this is how we know what we know, and my argument is that in a lot of, and then the last one pillar on epistemology, sometimes I use what we call traditionalism. That there's a lot of tradition. And tradition is like, no, we've done this always, and that's why we're doing it. And the weight of the different pillars, mechanistic arguments versus EBM and personal experience versus traditionalism, is different in different areas of the emergency department. I find. So in my video on orthopedics, I said that it's heavily mechanistic. And that's why maybe stuff like POCUS and other tools are not as useful there, because the mechanistic argument and the mechanistic approach is really helpful there. But the mechanistic approach is not as helpful always in medicine, where the pathways of disease and pathologies are intertwined in another way, and it's often more complex. And surgery is probably somewhere in the middle, right? It's both mechanistic, but there's a heavy tradition in surgery, as many of you may know, and also an attest to this may be that the abdominal pain book, is not evidence-based. It's more experience-based, and more like the bedside, how to do bedside clinical examination, but not with likelihood ratios, not with any of those things. That's one of the other books that I referenced, like CFU's Symptom to Diagnosis. So I think it's important to, when we go into the surgical part of the emergency department, not to like be a snob about, this is the best way to do it, this is the evidence-based way to do it. Well, epistemiology wise, we should have our knowledge in each of these three buckets: traditionalism, experiential, like personal and evidence-based, and then mechanistic argument or physiological arguments. And we just have to be aware that some of the arguments that we are going to be met with by our surgical colleagues may not be evidence-based, but they may be experiential-based, or cultural-based, or traditional-based. Doesn't mean that they're worse, but it's something to be aware of, I think, first of all. Sometimes it is, we should use our evidence-based approach. We should use the other approaches, and sometimes they are wrong. But we should not discard what our colleagues are saying just because, we think we are evidence-based or we want to do it in a specific way. Okay, and then I brought in this. If you want more talks about epistemology, then please check out the I Know Nothing podcast from Adam Rothman on the bedside rounds. And then I brought in biopsychosocial, and this is an area that I love to talk about. Not because necessarily the model is amazing, but I think the notion that a somatic symptom can arise, like a somatic symptom like pain can arise from other factors than just a stimuli in the abdomen, is really important when it comes to a lot of the abdominal conditions, especially the upper GI conditions, as is being backed up by studies. But I sometimes think that when we go into the surgical emergency department, or the surgical part, or we have a patient that is a surgical patient, or we think is a surgical patient, then oftentimes we kind of anchor on the biological part, and mainly the surgical biological part, not the medical or not the psychosocial parts either. So I think these models or these ways of thinking are important when we approach this apart, and just to be aware of these and how they may differ from the world that we come from. So just some examples of how the mechanistic argument sometimes, I think, comes through, is that in a lot of the medical stuff, if a patient looks fine now, but they didn't when they came in, the presentation is worrisome, like cardiogenic syncope comes to mind, or a subarachnoid, a thunderclap headache where 50% of the subarachnoids will look fine when you see them in the ED. That's not necessarily reassuring, so it really depends on the history. And with abdominal pain, at least, it's not that much different. It is usually a bit different, because if the patient looks good, then that's a really heavy likelihood ratio on sending them home, or at least doing expectation management. Come back tomorrow, or so that's almost always a green light to send them home. At least from my experience in different surgical emergency departments, and then there's some kind of somatic mechanistic argument there. I think that the patient, like if there's something in the abdomen that has gone awry or gone bad, then they should look bad, right? And there's tons of exceptions for this, but just be aware that the mechanistic argument often here comes through, and oftentimes I think it's actually quite useful, and you can often argue with the patient that it didn't seem like it seems like whatever it was the cause, it's gone away, and you can come back if it begins to hurt again. And that way it may be a bit more mechanistic and a bit less or I wouldn't say more simple, but it's there aren't as many traps, though there are some traps, right? So if you have an upper GI patient who is relieved by, well, I don't know, maybe what you call pink lady, which we probably shouldn't give anymore, but some kind of PPI cocktail, then that doesn't mean that they don't have an ACS, right? So just because the upper GI pain is relieved doesn't mean that you shouldn't think outside the box and think of ACS. So there are some, but that's going into medical country as well. Then there are some like the flank pain. There is some like the pain syndrome of flank pain. Sometimes or is commonly missed, or ruptured aortic aneurysm is commonly missed. With flank pain is the most one of the most common ways of missing a ruptured aortic aneurysm. So when you have a patient that, like, we know that NSAIDs like ketorolac or other NSAIDs work really well on like stone pain, like kidney stones or gallstones, and to such an extent that sometimes we just treat it, and then if they become better right away, then it's a good test. And we should probably be more worrisome sometimes, especially if it's an older patient with an atypical history or have never had kidney stones. So we have to think of it as in likelihood ratios, and I don't necessarily dare to rule it out just because the patient became better when it's flank pain, because the ruptured aortic aneurysm is luring underneath as a differential diagnosis there, especially in the older patients. But in general, if they look fine, then usually they can go home. That's more true here than it is in medicine. Okay. Then another mechanistic argument is usually the time as a test or serial tests, because if there's something gone wrong in the and it kind of relates to the first point here, then it should develop, right? It should develop, and if it's an inflammation, it would usually develop to some kind of even worse thing, like peritonitis or local abscess, or stuff like that. And so that's why, like, a really good thing in surgery is instead of doing too many tests, is observing and either sending the patient home if they can kind of manage their pain, or so that you can see them the day after, or using time as a test or serial tests to see whether there's a development in what you think is a somatic surgical condition. The caveat here again is that always think twice whether it could be a non-surgical thing like medical stuff such as DKA, ACS, and so on. But serial tests are really important in surgery, and probably because of the mechanistic argument. Then the psychosocial part, I just wanted to mention. When we approach our patients, I often find that we are too sure often that this is a somatic surgical course, and we don't at all, and we don't at all in general in medicine, but we less so in surgery talk about the psychosocial part of this. And this is really important that we also talk about this, and I've made videos about how to talk about this earlier, but in general, we should be better at getting into the psychosocial parts of the conversation as well, and making those differential diagnoses be on the list as well, not just as the last diagnosis that we think of, but quite up high. So the patient is aware that this can be something like expectation management. This can be something that you will send you home with, because if we don't find anything and we're not worried, and then there's not a small chance that this may be partly due to these causes. And I think it's really important to upfront to know about this for the patients, and just do it in a non-stigmatic, stigmatizing way, because this is something that happens and can happen to everyone. About expectation management, I think it's important to know that 20 to 40% will get what you call abdominal pain without no specific cause. That's quite common. And the source of that is ARCHM, the Royal College of Emergency Medicine. And then just on the psychosocial part, this is like the upper GI psychosocial pain patient. Like, I guess if you've been in the emergency, like the surgical emergency department, the psychosocial patients, a lot of the pain that we feel a lot of the pain that we feel in life often goes to the stomach, can go to the back, go to anywhere, right? It can become any kind of symptoms through somatization, and if it's not handled well, or there are other and with other factors, then it can become functional problems or chronic or long-lasting pain syndromes. And we do see it with maybe the post cholecystectomy syndrome, for instance. We see it with functional dyspepsia. Like, these are all conditions that like just happened to be in the surgical department, or because this was the organ that we think is the cause for this problem, but the common like underlying problem or issue for these patients are usually this kind of psychosocial somatization thing, and it's something that we have to be aware of and talk with our patients about in a non-stigmatizing way, right? The upper GI thing is that there's actually some studies from a Swedish psychiatrist that I know of. There's probably more, but that I know of, there's these interesting articles about that quite a big part of the upper GI pain patients that wants to seek emergency care has a psychosocial burden, usually anxiety spectrum disorders. You can check out the source here, in the next slide, I have one of the papers here that you can go through if you want to. But in general, it's just saying that patients with abdominal pain who seek emergency care have enhanced psychiatric comorbidities, especially those usually with upper GI problems. And that's like an average, but we usually, like, if you have the patient chart and you have the younger patient with a upper GI problem, then usually, if the blood samples are all right and it's not ACS or no medical problem, and you don't find any like gall problems, and then, like the classical patient is like having someone who has removed the gallbladder, who's already on high dose PPI, and who is young and without risk factors for any medical conditions, comes in with a high amount of pain in the upper abdomen. These patients, I find, in emergency departments are quite hard to get home, to go home. These patients, according to these studies, whether they have, especially if they have some acid problems, but even if they don't, they have a higher psychosocial component in their diseases than others. You can check out the source here. The last thing I wanted to talk about is so if you take the post cholecystectomy syndrome, I think it's important to talk about that, like how chronic pain develops and how once you remove the stimuli from a patient who's had pain in an area for a long time, whether there's a psychosocial component to it or more what you would call a plasticity or nociplastic component to it, where the brain has like kind of gotten into a habit of having pain in that area, then it's important to expectation manage with the patient once you talk about removing the gallbladder, because the pain might go on, and that's just knowing about these concepts is important when we approach these patients, right? Okay, I think that's all I wanted to say about these topics. The last bit is just, as we talked about in the introduction to this this part, then tradition plays a huge role. You can see it in the books that are still there, and it may mainly because some of the tradition is really good, but some of the tradition also through the EBM recent EBM literature has become something that is highly criticized but still used. And it seems like it's hard to, like, especially with the traditions in surgery, it seems, from my subjective perspective, it seems like these are hard to get rid of, such as giving PPI as one of the priority drugs for OPGI bleeds. The evidence there is really, really weak, has been weak for a long time, has actually never been that good, but it seems like a lot of the it's still the first thing I usually hear from surgeons when we talk about what is important for these patients, and not giving blood, not giving all the other stuff. Going on along the same line, the TXA, tranexamic acid for upper GI bleeds, the HALTED trial came out last year, I think it was, maybe 2 years ago, and the importance of that is just that, tranexamic acid, which is the next thing they usually talk about when we talk about PPI, upper GI bleed. Well, have you given PPI? Have you given TXA? I'm not saying that it's usually not a hill I want to die on. It's just saying that we should know as emergency physicians which things are really important, and that's through EBM. I'm not saying that we should just discard what they're saying, but the EBM doesn't support it. It's not a hill I want to die on, so I'll follow the traditions as long as it's not dangerous for the patient. But I don't want to prioritize it. So when you approach the GI bleed, don't think that PPI or tranexamic acid are the important stuff. It's not in the emergency setting. It may be, especially PPI later on, but not in the emergency setting. Okay, so it's important. It's a tightrope that we walk sometimes with our colleagues because we come from different traditions, right? Another one is an internal discussion is usually the nasogastric tube. Should this potential bowel obstruction patient or upper GI bleed patient or whoever they usually want us to give a nasogastric tube, do they need it? And there's definitely some who seems to be relieved by it, but the literature does say that the indications for this are diminishing, and it's one of the most painful or problematic and horrific procedures that we can do in the ED according to the patients. You can check out the link from First Time Ian where he goes through it. And so whether for diagnostic purposes or therapeutic purposes, this is more of a tradition thing, I think, at least in Scandinavia, where we haven't been able to get rid of this, and probably won't for a while. Again, not a hill I want to die on, but I'm just not that adamant of trying to push this through into the patient when there's other things that are more important. So I'll usually give it a small try, and if it doesn't work, then doesn't matter too much. All right. So it's more of this discussion is more of how do we weigh different tools in our toolbox, and some of the tools that are now falling out of favor should probably fall down on the priority list, and we shouldn't be too hard on ourselves if we don't get the nasogastric tube in on a patient. Probably it's not that important, other than the tradition that the surgeons are following. And if you disagree, please comment in the comments section. But according to the literature, what I can see is not a whole lot of benefit there. And I just wanted to finish. I'm not going to talk about the details about the exam of how to approach your patients, but in general, it's just nice to lying position, bend their legs, auscultate, and then do maybe POCUS before. Start on the least painful side first, and then talk to the patient while you examine the patient to look for distraction of the facial expressions. This is a really short summarization because I'm not an expert on the surgical part of the emergency department. I'm just probably average, but it's it's something that it's easy to learn but difficult to master, and that's why like entire books and entire surgical, like the surgical residents and attendings hands are magical, right? If they say it's nothing, then it's probably the best test. And actually, in some studies on appendicitis, where you take these scoring systems like the AIR score, I think it was the AIR score on this study. Then there's the study suggests that the best test is actually the surgeon's hands, an experienced surgeon's hands, right? Because they can take all of these things into like the minute cues into context, and and that's something that we cannot as emergency physicians. So we need to have respect for this and the surgeon's hands as a test. But know that it has a sensitivity and specificity as well, and know that all the tests usually should be serial, and so on and so forth. All right. And just to give you one of the rhymes here from the copy. So the diagnostic problem of today has greatly changed. The change has come to stay. We all have to confess, though with a sigh, on laboratory tests we must rely. And used to little hand and ear and eye, we culture this. We planned out that with case, and on the plates with hope we daily stare. Examine from the head and toes before you dare to diagnose. More harm is done because you do not look than from not knowing what is in the book. This book is on like all the diagnoses, right? So it's important to, this examination is really both traditionally but also mechanistically really important. Above all, do not try to spot because you think you know a lot. Spot diagnosis, like system 1 kind of diagnoses, but also maybe premature closure diagnoses, right? You should spot diagnosis you should hate until you are a surgeon grade. By then, of course, you will have learned some bitter lessons, and you're darned. So even though like this was written maybe, as I said, maybe I think 70 years ago, 60 years ago, there's great wisdom as well in these books out by Copy, and in the tradition of the surgeons. So yeah, we shouldn't discard it, but we should be aware of it, and we should criticize where appropriate, but also not die on the hill, like trying to push evidence-based medicine into some of the holes that will some of the battles that are not worth fighting at this point. So okay, then we talked about the second like kind of principle I want to go through: time as a test and risk of overdiagnosis. So we talked about a thing I really like in surgery is that serial exams are good. There is a tendency towards just doing the CT scan, especially if you're a novice at it, and especially if there are no follow-up opportunities, so that the patient cannot be followed up the day after tomorrow or after like tomorrow. Then you need to know the diagnosis now, and that's why sometimes CTs are usually being utilized much more. Also, there's lots of other reasons for it, maybe like not being able to cope with uncertainty and so on, but and not communicating with the patients about the risk benefit or harm benefit ratios. But in general, serial tests is something that's like a main thing in surgical emergency medicine, and the patient needs to be able to come back tomorrow when if the patient is under the threshold of something dangerous but not really ruled out, then they should come back tomorrow, and then you can do a ultrasound then or a new examination and do serial blood samples. I really like this thing, both on a primary care setting and also here. And I wish we would do it more in the rest of the emergency department, like the time as a test. So there's this concept that I just wanted to walk through with you, and just quickly. So Gilbert Wells talks about this the spectrum of illness. So let's say that this is the patient you think has appendicitis, right? And then the harm of treatment is usually stable. If we say it's treatment would be surgery. It's either if you have a mild appendicitis or you have a severe appendicitis, then it's stable, more or less, the harms. And the benefits are going up. So someone with really mild disease, in this case appendicitis, would have less benefit of doing surgery than someone with high, like a abscess appendicitis with high inflammation and peritonitis and so on. They have a great reason why we have to do surgery, right? So they have high benefit. The thing is, though, what we call overdiagnosis has creeped in a lot of areas of emergency medicine, and this graph continues. So where the benefits are on top here, there's a higher benefit to harm ratio here. Then when we move on this side of the maybe appendicitis like spectrum, then we are doing more harm, right? And why are we? How are we moving to the why are we detecting less and less severe appendicitis? I'm not sure that appendicitis is a good example of overdiagnosis, but this is the idea, because overdiagnosis is it's the same disease, right? If you look at under the microscope, it's the same disease here as it is here, but this appendicitis is dangerous and will produce more harm than good if not taken out, whereas this appendicitis is something that the body will take care of, or they will not notice, the patient will not notice if we do not diagnose it. And how is it that we get into this field, this area of the curve here? Well, that's by over-detection and over-definition, right? Over-detection would be we're utilizing, as we just talked about, more and more CT scans. So that's why we're moving into this area more and more. Also, we're getting better like guidelines. We're getting more risk averse. In general, we may not have we don't feel like we have time to communicate with the patient about the risks and the harms and benefits. We don't use we don't have the same doctor, so we don't have continuation in the care, and that's why we see a new doctor every time. And we rather just do the CT scan than having the serial examination kind of follow up. A lot of other reasons why, right? And I'll do a lecture on overdiagnosis in not too long, going through the details about this. But this is I wanted to bring this in because we're using a lot of CT scans in surgery, and this is one of the big problems that we're probably not talking enough about. It's important also to know that overdiagnosis, it is appendicitis. It is appendicitis. And you might call it a great catch if you did the CT scan on the patient who has a CRP of maybe 6, and you caught it had really minor symptoms. Maybe that's one of the appendicitis that years ago would just have gone okay. And I think it's a good thing that we're beginning to talk about other treatments and surgery for these like really milder cases, because then that's when overdiagnosis doesn't have to lead to overtreatment. We can treat differently depending on the spectrum. Okay. And these are some of the drivers. If you wanted to check out, you can check out these. Also, EM cases have a quick hit on overdiagnosis. You can check out quickly. So there's lots of drivers for this, and not only the more sensitive tests like a CT scan or the expanding definition of what is a disease, but also as we said, we have more faith in the CT scan than we do in the clinical examination. We are risk averse. We don't want to miss anything. And if we miss anything, we think that missing something is more dangerous to the patient than doing a lot of CT scans, and that's at least something to be discussed. And we probably should just delve into shared decision making much more than we are. Yeah. All right, that's all I want to say. I'll do a video on this later on. Okay, then always I always want to show you this as well when we have some kind of symptom group that we're talking about, and I like to do this 2x2 table to remind us that what we're doing in emergency medicine is something specific. We want to check out, we want to find the time critical conditions and the from the history the patient is giving us. We want to rule out the time critical conditions and the most likely from the post-test probability assessment of everything we've known about the clinical data from the patient, right? These things down here, the ones that are unlikely and not time critical, they are irrelevant. Oh, this might be costochondral syndrome or some kind of, this may be I don't know, some kind of rare thing in the abdomen. Yeah, it doesn't really matter. It's not time critical and it's really unlikely. All right, so it probably doesn't matter. These are the ones that we also always consider. These, however, are important. I just wanted to talk about this as well in abdominal pain here, because if you have the most common ones are these are the most likely, but non-time critical. These are the like 95% usually of the patients that we're going to see, maybe 80%, right? They have something that is not time critical, and oftentimes we'll just, in emergency medicine, we should always consider these, and if they become ruled out or comes below some kind of diagnostic threshold, according to the threshold model, then we don't have to. Then what is left is usually this, and the patient is usually interested in this, but that's not for the emergency department mainly to treat. It's great that if we can, but it's not our main objective. Where it is really important for us though, is that if we can rule out one of these conditions by having one of these conditions ruled in. My classical example is in dizziness, that we can find a BPPV and therefore rule out stroke if we can do it with confidence. But in surgery, in the surgical abdominal pain patient, oftentimes I see like, oh, this is a gastritis. Gastritis is not something that we ever want to talk about or diagnose in the emergency department, I think, because while it's very likely that it is gastritis sometimes, then it's really not something that it's not a diagnosis that we can make with a high certainty, because there's no good test with a high likelihood ratio. We don't. It's you need a gastroscopy, right? You need an endoscopy to actually make that diagnosis. So I would be in my chart when I chart, I would say this is upper GI bleed, this is upper GI pain. Because of maybe CRP or some kind of inflammation marker and reflux history, and we have ruled out the other stuff, then it's likely to be this, but I cannot say for sure, so I'll make the diagnosis upper GI abdominal pain until the gastroscopy can be done, right? Because we have to not frame our colleagues that are downstream from us. We have to also not put in, we have to be aware of not putting in this idea in the patient's head that this is definitely this diagnosis. We have to be kind of more vague, I think, if we're not sure, and we are usually not sure about these things when we send the patient home. That's a discussion for another time, but the important thing here is that don't try to rule in gastritis. It's really something that you need to rule out all the other upper GI / thoracic differential diagnosis for us to say, oh, the argument is more like, oh, it's below threshold for these things. It's not that this is ruled in. It's because these are ruled out with upper GI pain. Okay. And I don't know any BPPV. BPPV has a really, really good test with a high likelihood ratio. And I don't know any good examples of this in, well, it may be some kind of ultrasound finding, maybe a gallstone. If you find a gallstone and it really, but it's still something where you may have a differential on some of these, but it's still probably not good enough. So yeah, I'll just be careful ruling in these things. And of course the separus, even though the chance may be only 2%, then 1 in 50 does have the, like, if it's 2%, then 1 in 50 will have that diagnosis from the history. So always just have in the back of your mind that separus are, of course, when you hear hoofs, then you should think of horses in Scandinavia, not separus, but separus are not, and like the specific sepra is rare, like the Meckel's diverticulum is rare, but separas in general, seeing something rare is something that happens every day. Like if you take all the patients in the ED, one of them will have some kind of rare things. One or two of them will have some kind of oddity or rare thing as a cause of their abdominal pain. And yeah, so they should also be somewhere in the back of our minds if things are not aligning, if the CTs are normal but they're still like in disproportionately a lot of pain, then we also have to think about these. Okay, please check out the other videos on probabilistic thinking if you want to delve into this that I've made. Okay, moving on to the actual approach to the abdominal pain, and so there are like 3 approaches that I want to go through, and there's we can call it the 3 S's here. It's systematic approach, the syndrome approach, and then the systems approach. So if we take the systematic approach first, so how do we approach the patient with abdominal pain? So here's a ABCDE from the chart nurse. This is a 30-year-old female who's pregnant in the week 14 plus. Did I say plus 9? I mean plus 6 here. G3P2. So gravida 3, pregnant or sort of partus 2, uncomplicated pregnancy so far. She awoke a couple of hours ago with abdominal pain. What do you want to know? So the systematic approach, or the system 2 approach, is the one that we know. It's the OPQRST plus approach, or you can also use Socrates. And I made a lot of videos on how to ask for these questions. We shouldn't ask the specific. Like, shouldn't ask, oh, how did the pain come on? Where's the position? We shouldn't ask like closed questions. We should let the patient tell their story in a compassionate environment by us, and then they will tell you the story, and then we'll kind of check mark the things that we need to know. And attached to this comes up a differential with illness scripts, with the time critical and for the history that we are hearing, like the time critical illness scripts, right? That we need to rule out. And then we can begin on filling in the holes with specific questions once the history has been, once we have actively listened to the patient's story and checked marked out these and knowing why they're there and so on and so forth. Please check out my headache video for how to approach this. But we need to approach this in a kind of probabilistic way, like each data point is a likelihood ratio, right? That we just don't know how to weigh yet. For podcasts about this, check out Symptom to Diagnosis podcast by Adam Sifu here. And the OPQRST mnemonic is really, really good for especially pain presentations, and especially abdominal pain presentations. You need all of these to kind of get a picture of what the patient is presenting with. And so onset, position of the pain, quality of the pain, the relieving or alleviating factor, alleviating or like what makes it worse, what makes it better factors, the severity of the pain, and then the temporal, like if you had to draw a graph, how does the pain look? Like, is it colic? Is First it came on, and then it was colic, and then it came out and became constant. Like how does the pain in temporal measures look like? And the pluses is really important here as well, because you need to talk about the GI problems like diarrhea, output, like vomiting, and vomiting, color and blood and so on in the vomiting and the stool. And I just wanted to, and also vaginal bleeding and menstrual history if it's a woman, and the pregnancy. There's a lot in the plus when it comes to surgery, previous surgeries as well. And of course, you also do your maples, your medicine, allergies, previous conditions, and so on. I just wanted to delve on one thing before moving on the pluses, on the plus thing of the history, and that is, it's really important to talk about with the patient the qualitative symptom. So a lot of the patients will say, "Oh, I had vomiting." Okay. And then it's just, okay, vomiting is just vomiting, apparently, in medicine today. But it's important to know that the qualitative and the quantitative measures of the symptoms. So, okay, vomiting is like, did you vomit a lot? Kind of just like describe how much, especially, and did you have, did you come on without any kind of nausea, or did you have nausea before? Because, well, is it bowel obstruction or is it not? We don't necessarily have like nausea before, but it just comes because of an obstruction, and so on and so forth. So, and also with diarrhea, it's important, like, okay, was it water thing? What's the Bristol stool chart on that of the diarrhea? Not saying that you should carry that around, but more like, it's just a bit softer than usually, because a lot of the patients would use the words diarrhea for just a bit softer stool, but our differential is very different from someone with watery, like totally water thin stool with a high frequency. That's oftentimes gastroenteritis until proven otherwise. But if it's just a bit, like, sometimes we are confused when they say diarrhea, and then it's, oh, well, but diarrhea is a really common symptom in a lot of the inflammation abdominal pains, like appendicitis and mesenteric ischemia as well. So we really have to be careful here, and actually kind of qualitative go into what do you mean. Yeah, that's the rant I want to do on that. Let's go. So especially in surgery, the P and the Q, the position of the pain and the quality of the pain, even though all of them are important, these may be a little bit more important, maybe with the onset. But yeah. So, and of course, yeah, we talked about this should be probabilistic, right? So once this is a threshold model by Cashier. So the diagnostic threshold, the treatment threshold, and once you are above, like, the likelihood of a certain diagnosis, and of course there are more than one diagnosis, there are several diagnoses here, and again, please check out my other videos for a deeper dive into this. But once we get some symptoms told, and when we usually for some diagnosis will move over the diagnostic threshold, that's when we need to do the CT scan. And I often hear, like, with the patients coming in with screaming pain, sometimes some of my colleagues or younger colleagues will sometimes ask, oh, we have to do the full exam, we have to do, well, of course, if you can do it fast enough, but this patient needs a CT scan no matter what, because we're over the diagnostic threshold, okay? So there's not a lot of information that will change that. Even though we could do an ultrasound to see if they have cholecystitis for their upper right quadrant pain. Well, yes, but we do, but that will just not that'll just take extra time, and it will not change the management. It's not always the case, and I do believe in doing a thorough, good, focused examination to begin with, just like Kopi said. But we should also have in the back of my mind when we're just wasting time, and when the patient goes over the diagnostic threshold, and we just need to do this, okay, and get them to the scan fast. So yeah. Yeah, and please check out my other videos for a deep dive into the diagnostic threshold here and the Cashera model and the Fagin's nomogram over here. But just so all the data points are kind of moving us up and down in different differential diagnoses, such as appendicitis or cholecystitis and so on. And first, when all of them are below, like all the time critical ones are below a threshold or the diagnostic threshold, then we could probably send the patient home, right? And how we measure that, how much we weigh on different symptoms or data points, that's not always in the literature, right? So it's really about experience and tradition, this as well. And the patient doing fine now, well, usually it's all right, especially if they become good without any treatment, right? Okay, but let's delve into the two questions, the P and the Q. So the Q here, medical education online videos has a great approach to these things. It's now behind a paywall, but in general, there are 4 pain types when approaching the patient. There's the obstructive or colicky pain. There's the perforation kind of pain. There's the inflammatory pain and the ischemic pain. And they have different characteristics. And in general, the obstructive pain is usually like kidney stones or gallstones. There's something obstructing a hole. Usually, they want to move when they are in pain. They can find no rest. It's usually it's colicky, it's episodic, and by definition, sometimes, and of course, this is not like, again, this is a syndrome with atypical presentation as well. The kidney stone can sometimes have constant pain, especially if it's total obstruction and there's no peristalsis in the urethers. But in general, this is the classic description of the obstructive pain, usually sudden or subacute in onset, and then it's usually like a pain that cannot go away and is really severe. Often, like I think a lot of the kidney patients will sometimes quote that Napoleon had this as well, described as one of the most excruciating pains ever. So yeah, it's usually kidney stones and gallstones. That's a classical picture, but and other organs can though present like that as well, like the flank pain patient, and these with the aortic aneurysm, and also these the like if there's an obstruction on the bowel, then usually it doesn't necessarily translate to a classical presentation like this. It can, but not as often as the kidney stones and gallstones, in my opinion. And then sometimes this can also be detortion from the ovaries or the testicles, and that's usually with a kind of ischemic component to the pain. Okay, so that's the kind of obstructive syndrome or quality of the pain, right? Then you have another kind of pain syndrome. That's the perforation pain, right? That's usually sudden onset, like perforated ulcer, like sudden onset. The patient wants to lie still because they have peritoneal irritation or peritonitis. Usually they have constant pain with peritoneal signs, and it's like, yeah, it can be ruptured aortic aneurysm. They usually not necessarily, but usually more like on their other organs, like ulcer, ectopic pregnancies, or it can be secondary, like part of the inflammation process where it suddenly just bursts. The appendix just bursts suddenly. Sometimes, paradoxically, it will make your pain go away. And sometimes it will get this sudden pain when it bursts into the abdomen, and you'll have this peritonitis. So, yeah, as you'll see, these are not exact syndromes. These are with a lot of atypical presentations, but it's like a couple of things to think of, like the obstructive kind of pain, the perforation kind of pain, the inflammatory part kind of pain, and the ischemic kind of pain. The inflammatory kind of pain is usually a crescendo kind of pain. They will usually want to lie still. And this is in contrast to the obstructive kind of pain that you want to move, but these patients usually want to lie still. That's also always an ominous sign if they really just want to lay on their side and don't want to move as much. And usually they'll have like maybe some focal peritoneal signs if the stage of the inflammatory process has reached the peritoneum. Usually they may have other symptoms as well, like nausea and vomiting. These patients, obstructive patients, or twisting patients, like torsion patients, usually also have nausea and vomiting. Yeah, and they may have a little bit of inflammatory markers, but not necessarily early on, and we should not hang our heads on them. Yeah, it can be appendicitis, diverticulitis, pancreatitis, and so on. And pancreatitis can sometimes get this kind of perforation kind of pain as well, because they have these gall salts out into their abdomen. And then the ischemic kind of pain. The main thing about that is pain out of proportion. So you have someone with usually an older patient with sudden pain, maybe with diarrhea, maybe not. But if it's mesenteric ischemia, at least, then it'll usually like this pain out of proportion. It hurts in a really specific point, but it's like the subjective kind of pain is out of proportion to what you're actually examining, and it is usually morphine resistant. And that, like, mesenteric ischemia or torsion of ovaries, depending on the age of the patient, of course. But these are the things that, like, I usually, like, there are two syndromes of this. There's the kind of hernia, like the young usually have small bowel obstruction with ischemia, hernia, or gonad torsion, and the older will usually have mesenteric ischemia, or also small bowel obstruction, maybe kidney infarction. So yeah, so 4 kind of pain types, like obstructive, colicky, want to move, perforations, usually sudden, wants to lie still, inflammation, usually crescendo onset, moving, sometimes moving pain, wants to lie still as well, usually have other symptoms as well, like loss of appetite, fever, nausea, vomiting, and usually just subtle, but they're there usually. And ischemic, the pain out of proportion kind of patient, right? And there's attached like a likelihood ratio to all of these differentials with these kind of presentations. It's not set in stone, and itis can sometimes present with the other things. There can be ischemia in appendicitis as well. There can be ischemia in a orchitis as well. But it's like some kind of syndromes to hang your head on a bit. That was the cue with like the pain type and kind of. And then we move on to the localization based approach, the P. And that's like most people going into the room of the patient will usually say, oh, well, it's in the right lower quadrant, then it has to be appendicitis. And that's true. That is really likely. But just moving a bit further into this localization based approach, why and what are the caveats? Well, the thing about the nervous system and the nerve fibers, like, when you feel pain in the bowel, at least, and a lot of the organs in the abdomen, then it's stretch receptors. And the stretch receptors, they hurt in different areas than we think. They hurt depending on the embryological origin of that pain receptor. So you have foregut, hindgut, and then you have midgut and the hindgut. So you kind of have that's part of the explanation why, as I understand it, that the appendix, when you start having like early appendicitis, classically will hurt in the midgut because it's a midgut structure, and then it will move. The pain will move as local pain, like in the peritoneum, which is not innervated like the bowel here. Then it will hurt further down to the right, because that's where the actual appendix physically is located usually, and it will irritate the bowel wall, the peritoneum, right, the bowel wall. But to begin with, it's just the visceral pain, and that's localized in the center for the appendicitis, for the appendix, because that's the origin, the embryological origin. Just something to think about a little bit when you see patients early on, that the location of the pain is not necessarily where you think it is. Later on, though, you can oftentimes rely a bit more on it if it's a more developed stage of the disease. Then because the peritoneal signs are over the area where it hurts. Usually we have the abdomen dealt up in these like 9 quadrants, right? And there's usually like these, there's these different differentials to each quadrant, and these are good. These are really important, but I think it's the temporal aspect of whether it is an early disease or a late stage disease. Like, is it day 1 or day 3, 4 that they come in? Then the more later developed disease, then you can rely more on this than in the early low signal kind of. That's just, yeah. It's not as good a likelihood ratio, good a test to begin with, than it is later on. Okay. Sometimes it's called the angry robot. I just wanted to say that, yeah, there's different ways of putting in this structure or of 9 regions into pictures. You have the mid region, you have the right upper quadrant, right lower quadrant, left lower quadrant, and left upper quadrant. Then you have the epigastric slash thorax. That's the head of the robot, the mid one, and then the legs here are usually the uterus, bladder, and suprapubic. Another way of doing it, right? It's called the angry robot from Medical Education Online. Okay, another way that localization or of the pain can confuse us sometimes, or another layer of this this mantra of, well, it's good to think about these 9 quadrants, but there are like other things to weigh in when we're talking about localization approach of to pain. And that is the referred pain. And the referred pain is like defined, or like when you have to, as emergency physicians, think of referred pain, it's when we don't, if there's pain in an area, but we cannot reproduce it by touching the area. So the classical example would be ACS, right? Where you have someone coming in with arm pain, not chest pain, but just arm pain. And you cannot reproduce it by moving the arm, or there's no wound or anything, then we have to be concerned about referred pain from the thorax, and also non-referred pain, but other kinds of pain, of course, maybe a thalamic stroke as well, and other sources, right? But in surgery, there are these maybe classical ones. I think it's called, there is this one, if you have pain in your shoulders, then that's classical post-operative when you have gas in the upper abdomen, but also something that we see if there's other inflammations in the upper abdomen, right? Like gallstones, or like cholecystitis, or a spleen. I think it's called Kahn's sign, if you have shoulder pain and you have a spleen rupture. Also, like things pushing out towards the shoulder blades, the ovaries or uterus usually have this pain towards the back. So that there's different referred pain localizations. Then we have what we might call neighboring regions, and this is highly important, right? So as we saw in the pictures before, the abdomen is just, that's the abdomen, but it's really bordering a lot of regions that we have to think of when the patient presents with pain in the abdomen, because not all abdominal pain is abdominal pain per se. So I had a patient once, for instance, that came in with flank pain, and it really sounded like this classical colicky flank pain, but he was also a drug user, and IV drug user, and he had a bit of inflammation, or he had like he was subfebrile, and well, of course this could be a inflamed kidney stone, of course, but like when we examined him, when I examined him, it was more like, it was flank pain, but it was more like maybe to the midline a bit. I was like, just saying that the region, when we talk about flank pain, we have to also think about the back pain differentials. And this patient happens to have a discitis, or maybe even epidural abscess, I think he had. with endocarditis as well. So sometimes, like, even though we're in the quote unquote surgical part in the emergency department, we always have to think about non-surgical things and like think about just in an approach non-specialty based way. So yeah, flank pain, well, is that like the neighboring region there? If it's usually back pain, if it's a really high flank pain, then it can be also you have to think about thorax, like pulmonary embolism. So suddenly you're actually kind of working up both abdominal pain, back pain, and thoracic pain. And sometimes when I do this, like the non-emergency physicians in our department are usually like, why are you doing this? But it's important to understand these before just premature closing on the abdominal pain, right? You have to think about the other stuff as well, and sometimes you have to work up several things at once. Make up your mind if you cannot by clinical examination rule out the one over the other, like my IV drug use patient, then you have to examine several areas with more tests, right? That's what we do as emergency physicians. I just think it's important to mention this. Then when you go to the lower GI, of course, if you have pain in lower GI, then the groin for males are just next to that, and that's a common place for misdiagnosis. Both if you have scrotal pain, it could be kidney stones, but also the other way around, where you have lower abdominal pain and it's actually testicular pain radiating up. And the classical one is the upper GI pain. Upper GI pain, I always think we should, as a differential, have your what we usually call the 6 dangerous diagnoses, like for thorax, right? So it's and vice versa. Also for the medical patient coming with thoracic pain, we should think about the upper GI things, right? So they go hand in hand. So for the upper GI / thorax pain, you should also always think about the 6, the ACS, perimyocarditis, as well as tamponade. That's 2 of them. Then pulmonary embolism, pneumothorax. That's the 2 long ones, and then the 2 strange ones that are aortic dissection and upper GI problems, going from Boerhaave syndrome to pancreatitis. These are syndromes that commonly are misdiagnosed as thoracic problems, right? Okay. So once we have gone through all of these things with our patients, then we do have more. I ask, what do we want to know about this patient that I started off with, and we examine her, and we found rebound tenderness in the right lower quadrant, but nothing else. She described the pain as sudden. She awoke like these 7 hours ago. It's aching, and she just wants to lie still. It was 5 initial, and now it's 8, so it's like kind of crescendo but stabilized nature. It's constant pain. There's no vaginal bleeding, no GI bleeding, no constipation, no diarrhea, no anything. So it's monosymptomatic pain, but with a bit of vomiting and nausea. The pain time is like you're lying still. It's not pain out of proportion. She has slight inflammation and rebound tenderness. So we could probably make a differential here already. And what do we want to go like? You can think of it in your head. What kind of differentials you have here, and then you can like, what do I want to do now with this pregnant patient? All right, let's move on to the next kind of approach in the pain approach. That's the syndrome approach. So, and these approaches are synergistic. It's not one or the other. These are things this is why the abdominal pain patient is usually so interesting, because there's a lot of ways to think about the diagnostics with these patients. So just giving you some syndromes, like the generalized peritonitis syndrome, and you can read up on some of these syndromes on Life in the Fast Lane as well. They have a reference of these syndromes. So, for instance, the generalized peritonitis, the patient who has it hurts everywhere, and they're like rebound tender and all. Usually they have perforated organ. They may sometimes have ruptured aortic aneurysm. Usually they're more shocky than generalized peritonitis. But yeah, pancreatitis, severe pancreatitis, ectopic pregnancies as well. They may be more shocky as well, but localized, generalized, localized lower abdominal peritonitis is definitely something that you may see, or rebound tenderness and so on. And ischemic gut, flank pain. Well, if they have the flank pain syndrome, you have to think of the thoracic issues. Is it pulmonary embolism, for instance, kidney issues? Back pain issues, like the neighboring regions, but also kidney stones, ruptured aortic aneurysm, kidney infarct, and so on. Another syndrome is like, the patient with severe and sudden onset pain. Well, if it's severe and sudden onset without any inflammatory markers, like fever, then torsion comes to mind. Mesenteric ischemia, especially if they're older, perforated organs, aortic dissection, and stones. Right? If you do have fever and vomiting or diarrhea, then we can think of mesenteric ischemia. Now I'm listing not the most common ones necessarily, but the ones that we want to rule out, right? The common and time critical. Mesenteric ischemia, infarcted kidney stone, infected kidney stone, right? The itises, like appendicitis, diverticulitis, cholecystitis, pancreatitis, and PID, pelvic inflammatory disease, and the medical ones, right? The IBD, DKA, Addison's. These go into another syndrome where usually, like the medical kind of belly pain is usually more generalized. They usually have vomiting and nausea, and it's usually less acute and more diffuse. The right lower quadrant pain, like the appendicitis, you may have Meckel's. That doesn't really matter that much. You may have a low gallbladder, you might have low kidney stones, right? Kidney stones can hurt in different ways all the way down, and not uncommonly on the lower ones radiate to the scrotum, right? And the GY and OBG causes, such as ovarian torsion. We'll come to them in the part 2 part of this lecture. And then the right upper quadrant, you have your liver, where you might have preeclampsia, you might have Fitzhugh-Curtis syndrome, and so on and so forth. You might have hepatitis. So you have all your biliary diseases. You may have thoracic disease, like low pleural fluid. I'll link to you might have ACS, pneumonia, PE, and so on. I'll link to a great video from Rebellion later on, where what you have to think about on your right upper quadrant syndrome, and how you can use POCUS to go on the hunt for that. And then the patient with shock, like low blood pressure and pain, abdominal pain, is it sepsis from an abdominal source or not? Sometimes they have abdominal pain just because of the sepsis, but without any abdominal cause. Not uncommonly, they maybe have a huge bladder, and that's why they have abdominal pain. Ultrasound is usually useful here. Infected kidney stones, cholangitis, like ascending cholangitis, perforated diverticulitis or appendicitis, and so on and so forth. So you can go through the different kinds of shock, like the dehydration / blood loss shock, the obstructive shock, the cardiogenic shock, where you have backflow and also it hurts in your belly sometimes, and then also the distributive shock. And then there are some that are more common causes with abdominal pain, and that's usually the infection with sepsis. Yes, and the bowel obstruction as well. Vomited, swollen, diffuse pain, and no flatus. That's also kind of a syndrome more than a diagnosis. And then you can go on like creating these syndromes, and I think it's important to like kind of know once you get better at these things to like kind of know, okay, this kind of patient, how can I categorize this, and what kind of differentials are onto this kind of this category. And one of them is also like the CT negative syndromes. The syndromes where it's some kind of dangerous stuff, but it will be missed by a normal CT. and we'll go through some of those later on. But what comes to mind is a patient with mesenteric ischemia, where we just said, oh, well, that's nothing. The CT scan is normal. The patient has diarrhea or gastroenteritis. The pain and the gastroenteritis symptoms are just, well, that's gastroenteritis. And you didn't consider that this could be mesenteric ischemia. So the CT negative abdominal pain, just as the CT negative headache is something that we have to be aware of. So always before going into a study, always know if this test is negative, what am I going to do? Yeah. So exactly. So if we have the negative CT scan, but you still have a patient with abdominal pain, that's kind of a syndrome in and of itself, right? And when you go asking the radiologist to do the CT scan, you should always think in the back of your mind, well, if this is, as I said, if this is negative, what do we do then? And just some causes for the CT scan to be negative is is it the medical cause? Like, is this ACS? Is this DKA? Is the pain referred, right? Is it actually coming from a different region? Is this a hip pain? Is this testicular torsion localized in the abdomen? Is this right? It's coming from other regions, right? Is this actually like neighbor regions? Is this back pain? That's why you don't see anything, but just it's localized in the stomach. Is it thoracic, right? Or is the CT scan too insensitive to actually pick it up? It may be a gastric bypass patient with internal herniation where the CT scan is less than perfect. Let's just say that. It can be a gynecological cause where the transvaginal ultrasound is much better test, especially for maybe stuff like torsion. It may be another non-radiopaque thing, and so on. And cholecystitis sometimes it's not picked up by a CT scan. And do we need it? So this can be too. We don't. We have to think about the sensitivity of all of our tests, especially the CT scans as well. Can this be ruled out by a normal CT scan, right? And also the temporal measure, like early appendicitis versus late appendicitis, can this be ruled out by a CT scan? These are all things that we have to consider on the CT negative patient with abdominal pain. And it's always worrisome if the abdominal pain is getting worse or if they're not pain-free, right? And then the need for a different modality, as we just discussed. In short, I guess we have CT scans like the usual, like the CT scan without contrast, and you have the CT scan with contrast to look for usually inflammation. And then you have the CT scans with arterial contrast, looking for mesenteric ischemia, kidney infarctions. And these may be negative, like a kidney infarction will be negative on a normal CT scan. You may not even see clues about it. So you have to think about, what do I do when this scan comes back negative, right? Sometimes you want to have the radiologist in the real time looking at it. And if it's negative, then do the next contrast series. A common problem here is usually like the flank pain patient. Is this kidney stone or is it ruptured aortic aneurysm? Do I want to do a CT scan without contrast, or do I want to do a CT scan with contrast to look at all the other stuff? So take home here is just think about the precise probability of the common and time critical conditions before ordering the CT scan, and whether or not the CT scan will be enough to rule it out. Especially like the common ones, we miss mesenteric ischemia because of, well, we think it's ruled out just by having a negative CT scan. Okay. If the precise probability is low, though, if we don't have it too high a concern, then it's ruled out. If you are concerned, then we in like, at least in our departments, then we have to admit the patients, right? If the patient is still really in a lot of pain, then it's okay to admit them, even though it's the same kind of traditionalism as in orthopedic surgery. Like, the back pain patients should not be admitted. Well, sometimes they do have to be admitted because it's hard to keep up the flow with the patients staying in the ED for hours and hours and not getting better. We've tried everything and we don't want to give them too much morphine. It's better just sometimes to admit them and then have a expectation management talk with them, just like what can we do during an admission, right? But if none of that happens, and if it's low, if the pain is not severe, then it's ruled out, right? With a CT scan that's negative. That's the goal with the CT scans. Then I guess there's a syndrome I also want to talk about with the pain relief syndrome. And just to dispel this myth of, well, should we give or should we, like some of the nurses still come to me and like, oh, I didn't give any painkillers because I wanted to be sure that that the patient that it didn't affect the diagnostics. And there was this Cochrane paper from 2008 that says that the use of analgesia for acute abdominal pain does not mask clinical findings, nor does it delay diagnosis. So according to this paper, it's unethical to not give pain medications at triage just because you want to be more diagnostically sure. It doesn't hold in the evidence-based medicine bucket of epistemology. Then there may be some some specific cases where you may want to wait. Older patients that are like have problems with, like, that are sensitive to morphine, drug users that may be resistant to morphine or require high doses of it. Sometimes maybe if you, like, we talked about the flank pain syndrome and kidney stones or cholecystitis, where it's almost sometimes have a miraculous effect to give them ketorolac or diclofenac instead of giving them morphine. And there's this theory about spasm, like morphine can induce spasms in the papilla artery, I think, is and some of these peristaltic organs. So in my experience, the NSAIDs usually work really well in these patients, and morphine less so sometimes. But so there are some caveats and there are some nuances to this. But in general, yeah, give painkillers. Then, but we, as I alluded to earlier, like, we shouldn't rule out any dangerous causes of pain if you have an OPGI pain patient that gets the pink lady or get a kind of PPI or Gaviscon or anything like that, and the pain goes away, we should still think about the differential diagnoses, the dangerous ones, right? And also for the flank pain patient. Those are the two that comes to mind when I think about these caveats to the pain relief as a diagnostic group. But in general, then if the pain is better in the surgical and the gynecology population, then usually once you rule out the more difficult, or you've thought about the dangerous diagnoses or the time critical diagnoses, then you usually they can go home, and then they maybe need follow up the day after or a week after, but they can go home. So this pain relief, like the patient without pain anymore, it's usually a good sign if everything else looks good. And that's as opposed to, as we talked about in medicine. All right. Okay, so if we add another layer to this, then the syndrome that this patient comes in with, well, this is sudden onset right lower quadrant pain. We can think about what kind of differentials we have for that. And we'll move on to the systems approach. And every time I approach a patient, I usually, I do the OPQRST. I do kind of like, what kind of syndrome is this? Sometimes that's more like in the back of my mind, it's more like system 1, but sometimes I'll just to practice kind of like the subgroups of phenotypes of how different patients can be dealt into these once you get a few more data points on how to treat them, because each syndrome can be treated in a different way. Each syndrome has a pathway, right? So, this one you do CT scans, this one you give pain relief, this one yeah. But then we move on to systems, and this is one I usually teach because, and you usually use. Well, I kind of do a systematic system 2 read through of the systems that could be involved, right? Because it's so easy just to think this is surgery, but it's easily missed that it could be, well, medical, but also other stuff. So let's go through that. So I usually draw this, like, just think about it. Like, I usually write it out if I have a patient that is difficult. So surgical, that's a given. Abdominal pain, well, and we already went through that. And the surgical causes, depending on the location of the patient and the OPQRST and so on. But then, okay, could it be vascular? Usually, this comes into mind more so when the patient is over 50. Can it be medical, including also ophthalmology, like non-surgical things? Yes, glaucoma. It could be an endocrinological crisis with decay, adolescence, and so on. It could be IBD. Yeah, we have to think about outside the box. Could be urological, yeah, kidney stones, but also the testicles. Could it be GYN OBG? Yes, most definitely, especially lower abdominal pain. Could it be the skin? Yes, it could be, because of herpes zoster. Could be ortho. Well, I guess psoas abscesses. It could be inguinal pain because of hip problems and so on. And psychosocial. So I usually, like, approaching the patient, I'll think about these more systematically, like in a kind of forcing strategy, kind of forcing me to think about what can it be other than the surgical parts. Okay, so if we think about the differentials here, so obstetric, well, it could be pregnancy related. It could be the pregnancy that is being miscarried, but it could also be myoma and necrosis, which is something I've seen a couple of times, and it's one of these common but non-time critical conditions. But it's really good to see it with ultrasound, because if you see the myoma that's really hurting, and you can like measure it and see like and like do kind of a Murphy signs on it, and when you push on it and it hurts, then you have quite high sense, and you don't see anything else, and you have like it's a viable pregnancy, and you don't see any surgical things, because these patients usually have CRP and leukocytes, and the next step would usually be maybe we should do a CT scan on this patient. But if you see that sign, then you can be kind of, okay, that's all right. I have that's actually an example of one of the things that I usually will rule in if I see that really specific myoma with a big myoma that has grown during pregnancy. That's why I just brought it with here. Ovarian torsion, common also during pregnancy, or at least not uncommon during pregnancy. Medical, well, less so from what we gather. Can it be IBD? Well, always, but there's no diarrhea and no nothing else, so no. Kidney stones, sudden onset, yes. Could be hydronephrosis from pregnancy, yes. Could also be that. Like, just to go through the differential, I think this systematic approach is really useful, because you will not miss, or you will be less likely to miss these. So this is my forcing strategy for the abdominal pain patient. I don't use it as much as in other organ systems or other presentations, like chest pain. I'll use other kind of mnemonics there, the 6 dangerous ones, right? But here there's such a vast differential from such a vast neighboring region of symptoms of syndromes that may present in the same way that I think it's a good way to think of the differentials here. Okay, point 4, who is the patient? So it's really easy to just say, oh, when you go through cases, or you like all patients in the abdominal in the surgical emergency department has abdominal pain. Well, but there are subgroups, and one of the subgroups is whether what kind of patient do you have? Is it a highly comorbid patient, especially with gastric bypass? Is it the older patient with the flank pain, or is it a younger patient, and so on? So I think like this, who is the patient, is really important in a lot of aspects. If I should pick out some specific ones, like the age is really important, because with age, as we see in this, I've referenced it here, this great study on renal colic and when to do CT scans. Then they kind of like the young ones usually do not need it, especially if it's male, because yeah, then the differential diagnoses are quite narrow. There is an argument to be made that they should have a CT scans, like to know that they have two functional kidneys and don't have just one kidney. But usually, diagnostic wise, they don't necessarily need it. But then you go into but as you can see, the older the patient gets, like middle-aged, elderly, and and patients with no previous stones and high amounts of pain, these patients, like the older they get, they need CT scans. And why? Well, we can see it from this chart up here from the EMCC course manual, but there's other tables like this and other sources. Like the abdominal pain of unknown cause and itises are more common in the younger ones. But as you get older, especially you get more bowel obstruction, that's a CT scan usually. And you can diagnose it with ultrasound, but they usually want a CT scan as well. And usually the treatment is also a contrast series, right? The vascular ones that's a factor 10 increase, right? 10, 20 times higher risk of this being vascular, right? So alone from that reason, and that's where we have to be able to think, the vascular reasons, they are not ruled out with a normal CT scan. You need to think about getting a arteriography CT scan. So with age comes more omnious diagnosis, especially vascular ones we have to think about. Then you have the stoic patients, and also always stoic patients are always something that we have to think about, because even though they may not present with pain out of proportion, they will not say that it's hurting a lot, but they came in the middle of the night, and they're a farmer from somewhere and have never been here before and didn't come in just because. Not saying that anyone does, but these patients especially do not come in for no reason, and they come in now even though they say, it just hurts a bit. These are the patients that we have to think of as in severe pain and maybe do have a low threshold to do a CT scan. Who's the patient? Well, the gastric bypass patient is a chapter of its own. The ACEP, the American College of Emergency Medicine, has made their entire own homepage in collaboration with the bariatric organization in the United States, because it's such a complex group to take care of. In general, the abdominal pain patient, if you do not find another cause of their pain, if they had gastric bypass surgery before, then you have to rule out internal herniation, and ruling out internal herniation is hard, or is impossible with a CT scan. The studies differ on the sensitivity, but it's really, really hard. And usually you'll just have to admit them for observation, even if the CT scan is negative. So you just admit them in wait of the CT scan if you don't have a high likelihood for this to be internal herniation, but you cannot rule it out even with the CT scan. So the best way is just to find another cause for the pain. And as they say in this is a small right out from the surgical book in Stockholm. It says it kind of says the same thing. Like, these are hard to evaluate. It's only like, yeah, my friends who know about a lot about this, or who has experience more than I have in the emergency department's surgical part, will usually say that like these patients, you admit them, and it's always like, it's only a surgeon who can send them home in my book, unless you find a different cause of it, cause for the pain. And well, it's really on it's a balancing act, because you don't want to go into the abdomen either of these patients, because there's a high risk of other stuff. Yeah, so it's really like when to do the laparoscopy, not too late, not too early. Like, you have to do it just right. It's a Goldilocks diagnosis, and that's why it's really important when you do the gastric bypass to talk about these things with the patient. I think it's like 10 or 20% they have complications like this, and other complications, but 80% becomes good. All right, just saying that patients with like Roux-en-Y or the gastric bypass with pain really depends also how long time since it happened. And here I just wanted to draw your attention to this. At any time post-operative, intermittent vague diffuse abdominal pain, signs of bowel obstruction, concerns for internal herniation. They don't have to have bowel obstruction pain. They just have to have this kind of diffuse pain. Yeah. This is from EM Docs. I just wanted to show one more. This is from the Clinical Pearls for Emergency Care of the Bariatric Surgery Patients. I think this is from ASMBS, the organization. This is so detailed and so hard to get an overview on. But if you are interested, or if you are someone who actually sees these patients outside of the like in all, like also early after surgery, then this may be important. But in general, it's just saying this is complex, and you can check out the ASIP homepage to get a better overview. Yeah, but this is also a resource out there to check out. All right, point 5, and that is POCUS. And I always wanted to make it like a broader video about point of care ultrasound and a more like probabilistic approach to it, but there's so many great videos out there, and I haven't had the time to do it. And I think maybe I won't be adding too much on it, so I'll just for this point in time, I'll just show you these references, and I'll usually say like these are when I sometimes do educations in ultrasound for our junior staff, and I usually give them this, like, okay, so you have some videos that are short videos for ultrasound, or POCUS, right? And these are like some of the great references here are 5 Minute Sono by Jacob Avila, an emergency physician with passion for ultrasound. He also had a podcast on Core Ultrasound page that you can check out. Like 5 minutes videos with like they're not really in depth, but they're really like to get going and to kind of get an overview. They're really, really good, and but the podcasts are really great for the in-depth part. The EM Cases POCUS videos are really good as well. I do prefer the band POCUS videos if I have to choose between those, but they're like 10 minutes long, and then they go like them into moderate depth. And then the POCUS 101, they have a block that was much more detailed, but they will also do videos that are good to start like to read up on an area. So I'll start with these. Then a bit longer videos, I will highly recommend the Metro Health Emergency Ultrasound YouTube. It's really, really good. I've loved this homepage because it's just up our alley of emergency medicine and ultrasound, and just 30-minute videos where they go through, if you know POCUS, they go through some of the more detailed things and the sensitivity and specificity, and give you how to think about it. It's really good. that, and the CDU, also a really under appreciated channel from Australian radiologists with a like teaching emergency physicians to do POCUS, really like modern foam kind of pedagogical way of doing it. I highly recommend these videos as well. Then you have like I mentioned the Core Ultrasound podcast and this new FUSIC SI, which is I haven't delved too much into it, but it looks really great. And then there's this Utah POCUS, or like especially like I like this page. Is really there's a lot of material there, and the videos are long. And it's more like a course that you take that is free, but they do have this probabilistic approach to point of care ultrasound. I really like that as well. But it's mainly or a bit anesthesiology biased, and a lot of it is what you call focus the heart, like the step before doing a echo, but after doing a POCUS, like the next step from doing POCUS of the heart. Yeah, that's what they kind of specialize themselves in. Then you have the home pages of evidence, ultrasound gel. That's more like of a article page where they like kind of sample all the articles on POCUS for emergency physicians. And then you have POCUS Atlas, which is also is both a evidence archive, which is, I mean, I like their evidence archive. It's a bit shallow, or it could be much more in depth. So it's a bit, yeah. But I like it just and I'll use the data in the next couple of slides as well. So I like it, but I especially like it because of their when I educate, and when you want to see an example of some kind of ultrasound finding, then you can check out their picture archive, and then just that's how that looks. That looked like, yeah. And then for cases, I highly recommend you check out Life in the Fast Lanes POCUS cases by he's called Riley, I think. He's a great educator, and he's been on SMAC as well. He has like maybe 100 interactive cases where you go do it like step by step. I love these cases. I would wish there were more. Then there's one that I haven't delved too much into called Ultrasound Box, which one of my colleagues recommended. I think it's okay, but not as good as the Life in the Fast Lane one. Yeah. And I'm not sure this may be an error. I'm not sure they have cases, not something that I've seen anyway. Then books, there's Sony, which is one of the like Bibles or for emergency physicians going into ultrasound. I'd like to point out the ED book, the Eddie book, I think it's pronounced. It's like a Canadian concept for emergency medicine physicians or providers with a course, and it's an ebook they have. But I like the principle of the way they write their book. It's very oriented on probabilistic thinking and pedagogical principles, and like one of the mantras is that you have to understand like how to be able to get the pictures before you can before you can do an analysis of them. So like step one, as I usually tell my students in POCUS, is like we have to be able to get the picture first. And that's what you have to, like the first many examinations, that's what you have to be able to do, and how to get the picture better. And that's something that you'll develop over your entire career. But and then you can interpret the pictures once you have a good, like you got getting the pictures down. And that's something that they also recommend in their book. And then I'll just tell you about like the Israel, like POCUS Manifesto book is an internist who has just argued that, made an entire book arguing that why are we not moving over to POCUS. Me talking about overdiagnosis, I've been really skeptical early on about POCUS, but I do think a lot of the arguments for the stethoscope, that a lot of the problems that the stethoscope had when that came in to practice, a lot of the same arguments are being done about the POCUS or ultrasound. And he goes through the historical thing about this in the book. I really like this book, even though it's kind of basic if you have been into POCUS for a while. But I think it's a good read for why we should be doing this, also in a probabilistic way, why the POCUS we're doing may be a how we should have done with the stethoscope a lot of years ago, like with kind of distributing pictures and kind of to be able to analyze what others pictures are showing us, instead of just like the stethoscope, it's only us who can listen to it, so it's not something that we can show others. So POCUS has a lot of higher potentials, besides being just more sensitive and specific, and but also with caveats. So we need to have respect, and it's a tool, not a it's a tool like everything else. All right, enough about the references. Let's go to oh yeah, there's one reference I just wanted to mention, and that is this this Danish article, Andersen and Brodersen, who is a professor in overdiagnosis, or a professor in primary care, and a bit controversial, but also a speaker, speaks a lot about overdiagnosis, and one of the front runners of overdiagnostic studies. He and his colleague and others have done this great study in private practice, where they have shown that the majority of the patients where we do POCUS, they feel like they're being examined more. And I think it's partly because, sadly, that the clinical examination is not valued as much anymore in the modern society. And partly because, well, we don't trust, we don't have continuity, and with the same doctor, we don't get the same alliance built up. Well, to compensate for that, usually as I alluded to, you do a CT scan, and I guess doing a POCUS sometimes, if that is what the current currency is for conveying that we're listening to the patient in a good way, well, then we should do it. Then I think we should do the ultrasound, but be aware of the incident aromas, and be aware that we're doing POCUS, not radiology, or not RADIUS like radiology or ultrasound. We are answering yes/no questions. Do you have gallstones? No. Yes. And I do I believe this, the patients I usually see where we do ultrasound, they usually are easier to send home because they feel like they've been better examined. You can also talk with them right while you're doing the ultrasound, right? And you can give them the probe and say, where does it hurt the most? And then they can see into the stomach, right? And they can see in the picture, oh, it looks okay. Or, okay, that's an appendicitis, right? So there's a high power of the POCUS, and usually I will use that instead of a lot of other examinations like auscultation of the stomach. But I think it's a tool or a toolbox, but it's a really powerful tool, but we have to have respect for it. But it can be used in this way to make the patient, as part of the compassionate care package that we should deliver, then this could be a tool as well. Okay, so what is the evidence for, we need to know the sensitivity and specificity for these things. And in short, I think, not only in abdominal pain, but in general, that the point of care ultrasound especially for the novice user, is a rule in thing, but not a rule out. And it's POCUS, not RADIUS, not a radiology ultrasound. So it's yes, it's specific yes/no questions. Is there free fluid? Yes, no. And but as part of this, we also we need to know the sensitivity and specificity in ideal circumstances. And I say ideal circumstances because your sensitivity and specificity goes up as you become more experienced. But a lot of these studies are done by usually experienced point of care ultrasound users. So use it as a rule in, but not as a rule out to begin with. Use it as you would the stethoscope as one data point, right? And if you don't have a yes/no answer to your ultrasound, then as the Eddy book says, then move beyond it. Then go beyond it, or skip the test as if it was not done. All right. So for ruptured aortic aneurysm for more than 3 centimeters on the ultrasound, then it has a sensitivity of 97.5 to 99% with a specificity of 99. Right, it translates to this really good likelihood ratio. However, as we usually educate, 90% of the aortic aneurysms are infrarenal, but on 10% are suprarenal. The suprarenal ones are quite hard to find because of the colon going, the transversal colon going through the area, and usually it's a lot of shadow there. So in general, this is believable, but just be aware of that. This can be a problem. So you need to follow the entire length of it to find the all of them. For bile, well, in general, I mean, for cholecystitis, the sensitivity is really good, and also for bile stones. Is really good because it can see some of the non-radio opaque ones. But the CT scans from the studies I could find was not that much worse, and it kind of depends on where you are in the diagnostic process. I think it's quite powerful just to with the patient with the right upper quadrant pain to say, here's your gallbladder. There's no free fluid. There's no stones in it. There's no and then you can kind of it's quite a powerful tool when you have right upper quadrant pain to just check that out. And when you do find the cholecystitis, then it's kind of obvious, and usually, the surgeons usually want a professionally done ultrasound anyway. But I think with a lot of these things, ultrasound, as I said, is a rule in. But you should use it as a rule in test. But it's one of the main purposes for, besides making the patient feel more thoroughly examined in the modern society, which is important. Then it's also a test that we use for hurrying up a process, hurrying up the process so that the patient can get admitted or get the CT scans, because we can get the diagnosis or a higher likelihood of diagnosis early on. Oftentimes they will need additional tests to confirm our suspicion, but usually the specificity for the ultrasound is high enough for us to say this is probably it, or it's at least high enough likelihood ratios to just get the ball rolling, get that kind of going, and then until they can get the verification exam, whether that be a CT scan or a radiological done ultrasound, then so be it. But as we'll see, for small bowel obstruction, this is something that is really important because they have a high mortality per hour. waiting in the emergency department. And if we can shorten that time where they wait because we see dilated bile loops or to and fro motion or a keyboard sign, then we can say, well, this patient needs an urgent CT scan, even though the symptoms may have been a bit diffuse. So I think it's really a powerful tool, this. Speaking of it, here's the sensitivity and specificity on the small bowel obstruction with the, and that's only for diameter, like dilated bile loops, more than 25 millimeters, not looking at the other criteria necessarily, like keyboard sign or tanga sign, like a bit of edema, and the to and fro motion. But yeah, it's really easy to see it when it's there. I would not rule it out, but it's easy to see when it's there. I would use the specificity here especially. Appendicitis is for pediatric population. It has a good sensitivity and specificity, but not great. So if it comes back negative, but you have a high likelihood ratio, I would not rule it out. Then I would admit the patient for observation or do a repeat scan or repeat ultrasound later. Transvaginal ultrasound, we'll look at it later, but it's more on the spectrum from point of care ultrasound to expert Euro ultrasound, like radiology ultrasound and beyond. It's more towards radiology ultrasound than it is POCUS oftentimes, because it's not necessarily yes/no questions that you answer with a transvaginal ultrasound. And so it's a bit harder to compare with POCUS, but in general, when you have the specific questions, is it a viable question? Is it a viable pregnancy? Yes, no. Then it is a good, really, really good test. And also for ruptured ectopic pregnancies, if there's free fluid in the abdomen, then it's a surgical matter, right? If there's free fluid in the right upper quadrant, I think it is. Yes. Pelvic free fluid or Morrison's pouch. Yeah, if it's Morrison's pouch, then it's really, really, really high likelihood ratio. If it's pelvic, then it's highly likely, but still not as much as it could be, right? So there's other causes for pelvic free fluid, also presenting like a pregnancy-like state. All right, testicular torsion. I've done a video on this. Here's the link. But in general, there's not a lot of studies out there by emergency physicians doing this. In my short, I did a small review on this, and in my review I found 4 by emergency physicians, and the sensitivity is kind of good, but it's not that good studies. In general, I would say like for testicular torsion, it's really good, but you should always do it with the exam, and you should always do it with you should do all the tests. Like you have to do spectral Doppler on the veins. I would say, if you want to rule it out. But if they do have a twist score of more than 2, then I would probably go to a radiologist or a urologist to kind of discuss the case at least. The best thing here is that if you find something else like epididymitis or an architis or a trauma or anything else, then that could explain the symptoms, then it's a great, oh, this is it, this is the cause of the pain, then like that's a rule in, and you can rule out the torsion by that. Hydronephrosis and kidney stones. I believe EM Cases has done a series on this, where it's kind of, it's not that useful, but I would say it seems like if it's really good, like to say it's like, is there isolated, is there hydronephrosis or not? Then it's quite a good test, especially if it's moderate to severe. You just have to check that there's no like the black in the middle of the kidney, that it's not a vessel, and you can check that easily. With a normal color Doppler. But whether or not to couple this with kidney stones, like if you have hydronephrosis on the one side, I would say like there's a likelihood ratio there, and there's it's a good data point to have, especially like at least compared to the urinary dipstick, where it's like blood as well. It doesn't have that good a sensitivity or specificity either. So with a kidney stone patient where you don't want to do the CT scan because it's a young patient, then and they should have a healthy kidney. Then if you examine both kidneys and there's no hydronephrosis on one side, but there's a bit of hydronephrosis on the other side, but no creatinine, maybe a bit of blood in the urine, then I like to do this test because it adds just a little bit. I'm not hanging my hat on it. On the older patient, I would not hang my hat on it, but in the younger patient, I'll just say, that's just one more data point telling me that there's it's very likely that this is like a kidney stone. Yeah. And then the fast scan, and one of the things with the fast scan is that I think is 250 or maybe 500 milliliters that you have to have in the abdomen of blood before it's detectable. It's a bit less with the transvaginal ultrasound in the suprapubic region, and then there's also it depends on the Trendelenburg. If you have the patient in Trendelenburg, then it's like the test is dynamic, as they said in the Eddy book from Canada on POCUS. It's dynamic, so you can tilt the patient and then you see the fluid going down into the abdomen if you have the Trendelenburg position. At least if there's no adherences in the abdomen, like catching the fluids. It's a bit different with your pediatric patient as well. It's very insensitive, but still kind of specific. But so be aware that in the pediatric population, it only has a sensitivity of 35, but a specificity of 96. So is there fluid? If there is fluid, then there is somewhere a hole somewhere. But you cannot rule out in the same way as you may want to do sometimes in the adult patient. If it's an hemodynamically unstable, at least, patient, then the fast is really valuable. If it's a hemodynamically stable patient, then it's not as valuable as with the unstable one. Sorry, I did unstable one, high likelihood ratio if you find blood. But the stable one, you cannot rule it out, and you should do a CT scan if you need to. Okay. Just getting an overview of what we're examining in the abdominal emergency department and how good the test it is. In general, it's a really good test, especially for ruling in. All right. Just as an example of a good lecture on this abdominal ultrasound area, and getting into the vibe of neighboring regions, and not everything in the abdomen is not every abdominal pain is of origin in the abdomen. You could check out this Rebellion 2021 lecture on right upper quadrant pain. Where and why the ultrasound is such a valuable tool there. Okay. Moving to the end of this part in abdominal pain, I'll just talk about, there's different kinds of CTs as well that we have to consider using, right? So which one do you want to use? And this is oftentimes an important thing. So the first step is, do we need to get a diagnosis on this patient? And oftentimes you don't need the CT scan, even though we're doing it. Serial exams or observation, and as we talk about overdiagnosis and all of these things, CT scans should probably be utilized much less than we are, and we should know the limitations of it, and so on and so forth, as we talk about through this lecture. But once we wanted to do a CT scan, we need to know what kind of CT scans do we have. So let's say we have this patient, 86-year-old male, known with benign prostata hypertrophy, HFrEF, so heart failure with reduced ejection fraction, and AFib, sudden onset severe right flank pain, hemodynamic stable, subfebrile. Flank pain and right upper quadrant pain on exam, dipstick +2 for leukocytes, negative for nitritis, and +2 for blood. What are the differentials on this elderly gentleman? Well, flank pain, ruptured aortic aneurysm until proven otherwise, right? Early one because he's hemodynamic stable. Kidney stones, of course, could be infected because of his subperability. Could he have pneumonia, like neighboring region? Yes, he could have neighboring region back pain, and he also could have thoracic pain, like pneumonia, and maybe a pulmonary embolism as well, and so on. Could it be appendicitis? Yes, maybe atypical because it would sit on the right, like on the flank, and that's atypical. But elderly patients also have nerve endings that are kind of weird, and they may not feel pain the same way or the same area as younger patients would. Mesenteric ischemia is definitely also because of the suddenness of the pain. So what do we do? Do we do an ultrasound because we might think it's an upper quadrant pain with cholecystitis? Do we do CT with contrast because we might think it's an appendicitis, a bit atypical, also will catch cholecystitis, and would probably would catch a big RAA, but not a minor one. Another small tear, if that's what we're looking for. Do we do a CT arteriography because it may be a mesenteric ischemia, also maybe kidney infarction, and so on and so forth? Or do we just do a CT scan without anything because it's just a stone? So these are the questions that we often have to be aware of when we're doing differential diagnosis in the emergency department. And it's easy to just order CT scans on all of these patients, but I specifically think in the older patients, I think if they have not been examined before with a CT scan and they have this kind of pain now that we don't know the origin from, and especially if we just think it's kidney stones, this is another patient that we don't scan for kidney stones. We want to find that kidney stone if we need to, and also because the subfebrile could be a infected stone, right? Avstängt pylit or obstructed pyelitis, or I think it's called maybe, at least in Swedish. So and sometimes we have to do sequential CT scans, right? First the CT scan, first is like the working horse, the CT with just normal contrast, to maybe rule out the worst of these, and maybe rule out this, and then the cholecystitis, the back pain ones, not as much. The thoracic ones, well, we can also add just the thorax ones. Then you come into the problem, should we do a with pulmonary embolism series, or should we do a just plain series on this? Lots of decisions here, and that's why our pretest probability assessment is really important before going into these, and also seeing which differential diagnoses are over the threshold, and which do we actually need to write up and ask for. Sometimes the most sensible way of doing this is going sequential, like first the contrast, and then the CT arteriography. And you can stop if you find something with the CT contrast, but you've already in your mind set if that is negative, then you'll do the CT arteriography. If the more likely diagnosis is the inflammations, more so than the mesenteric ischemia. So just to illustrate how difficult this is, and why I think it's so fascinating and interesting with these patients, and I think it's often overlooked the complexity of this decision. But which kind of CTs do we have? We have the no contrast CTs. These are good for kidney stones, for blood, for gas, and most other stuff it's too low a sensitivity and specificity. It can find some other stuff, but the sensitivity and specificity becomes too low, so we'll need the CT contrast for that. What other CTs do we have? We have a swallow contrast, so you have a specific contrast where you swallow it. swallow some contrast medium. There's this called gastrographin contrast, which is also the treatment for small bowel obstruction. Oftentimes, it can also be what you use for esophageal stuff, like a Bohave syndrome or esophageal rupture, right? Where you need to find that, or you might use it in achalasia, where you need to like find strictures of the esophagus, or you might find something else in the esophagus. That's when you use those kind of swallow studies. Then you have your CT venogram. It's not as often utilized, but if you have a DVT that is going proximal to the like, you cannot, it doesn't stop when the leg becomes the abdomen, and you cannot follow it with the ultrasound. Then it's something when you want to do a venogram of the abdomen to check for both cancer, but also how big is this thrombus? Is it going all the way up to the liver? Sometimes it is, and then it may be a thrombus that you want to thrombolize or do some invasive stuff on. That's for a vascular surgeon to decide. But yeah, and then you have like some other stuff like Budd-Chiari syndrome and so on, where you might need a venogram as well. Then you have your CT arteriogram, and these are the ones that are like for mesenteric ischemia. And remember, mesenteric ischemia is a syndrome of different presentations. There are your venous mesenteric ischemias, where it's venous emboli. These are rare, I believe. Then you have your arterial emboli. These are more common. This is usually your patient with AFib and heart failure, low flow states with a high coagulability, where you get these thrombus. Just like they can go to the brain, they can go to the kidneys as well and become kidney infarctions. You can go to mesenteric ischemia as well. And if they don't have AFib, they should be worked up for AFib, right? But also you have this more like claudication kind of mesenteric ischemia, where it's like meal, like that's a classical meal presentation for it. Like it is post-radial pain in the abdomen. So there's different syndromes within the mesenteric ischemia, and the emboli ones are the ones that are really dangerous. But the other ones also carry a high mortality, but more so I think because of the underlying conditions. Then you have your and then you do your contrast for everything else. So I hope I've illustrated that the complexity of this decision in the emergency department, and how, well, once we're over the threshold, or we need to do some kind of study to know, well, then this is the decision we have to make. But oftentimes we're under the threshold, and we have to, like, okay, the patient can go home, we have to examine them tomorrow. That's like most of the decisions that we make on these abdominal pain patients in the ED. Go home, go not, follow up or not, CT or not. That's kind of, yeah. And of course, POCUS. And we talked about it speeds up the process sometimes, but and for a few diagnoses, it's better than the CT scan, but or especially for children where we want to reduce X-rays. So, okay. In conclusion, the approach to the patient with abdominal pain is multimodal, and it's really about both OPQRST, it's localized based, it's time as a test and serial exams. It's thinking about the syndromes and knowing quickly what kind of syndromes are important and what differentials are on, and how to treat those and diagnose those. It's about mechanistics and tradition and evidence-based medicine, which is maybe a bit more on the balance on tradition and mechanistics than we're used to in medical emergency medicine. It's about who's the patient. Flank pains are not just flank pains. We need to do CT scans on the older ones, especially if they're not known with kidney stones and we don't have any better differential to find. We have to think about the biopsychosocial and communication aspects of these, because a lot of these, 40% of these, would have abdominal pain without any specific cause, especially the young ones. And how do we go about that? How do we talk about the psychosocial aspects of this? nociplastic pains that may occur when we have more long-lasting pains or acute on chronic. Maybe even like complex patients, like bariatric patients with the gastric bypass and internal herniations who come again and again to the emergency department. And also pain relief and diagnostics, and there are many more aspects like this. But I hope I've been able to give you some kind of panorama of what goes on in my mind, and I think in a lot of the resource, in a lot of the minds of others and my colleagues and the ones that are really skilled in this when we approach the patient. And I think we should use some of these. I use all the time, like the OPQRST every time, and localized based all the time, syndromes and POCUS and all of these all the time. But I think all of these are become data points in our assessment of the patient. And our main objective here is to convince them that we are either worried enough to do the scans, and then we need to know what kind of scans we need to do, or not at all worried, and they can go home, or somewhere in between, so we can have to go. They have to come again for another test. So that's abdominal pain, and in the next part we'll go through gynecology as a subgroup of both abdominal pain, but also with vaginal bleeds and so on, pregnancy-related issues. Okay, thank you so much. And just to wrap up our case, well, what do we do with this patient once we have all these data points? Well, that's the problem, right? That's the issue. Do we do a CT scan on this patient with this viable pregnancy and no cholecystitis on the ultrasound that we did bedside? In this particular patient, because of the location of the patient's pain, because of the rebound tenderness, because of the we actually did do a CT scan, and we asked specifically for appendicitis because of and she turned out to have an appendicitis, which is often problematic in pregnancy, right? It's hard to find, and so just to have the conclusion on this case.